Well, good afternoon, and thank you for the honor of being here to tell you a little bit about how we use GIS to deliver healthcare in the Inland Empire. I'm going to set the context a little bit to begin with. First is that there's a difference between health and healthcare. Health is our ability for our bodies to achieve the goals we set for ourselves and to, not to take something from Kaiser, to thrive. And health care is actually the management of health breakdown, for the most part. So it's time for us to begin to look at bringing these two together so that we truly are creating health in our healthcare system. So, what is the Inland Empire? Because I think this is a very international group, and my guess is that outside of it being the home of Esri, you don't know much about us. So, the Inland Empire is actually over 27,000 square miles in geographic space. And outside, we do not have beaches, but we have deserts and mountains and valleys that are highly populated and sparsely populated. It is made up of two counties, which are Riverside and San Bernardino County, and has a population of about 4.5 million. To set this in some context, of our 50 US states, 10 of them have a smaller geographic map than the Inland Empire, and half of our US states do not have the same population. So that gives you some idea of who we are. Some more important statistics about who we are is that the average household income is about $60,000 on average between the two counties. But what that doesn't tell you is that for the US, the household poverty level runs at about 13.6%. In San Bernardino County, it's 18%, and Riverside, it is 15.6%. One of the saddest statistics about the Inland Empire is that 1 in 5 children who start school will not graduate from high school. And that is heartbreaking to me. Such a loss of potential for the world that is there in that statistic. And our last statistic is that the US unemployment rate runs at about 3.6% currently, and we are slightly below double that amount. So who is the Inland Empire Health Plan? It was started in 1996 by the state of California, where counties were allowed to form a care delivery system or an insurance plan that was independent of them but still controlled by them to deliver Medi-Cal benefits to people who were eligible in their counties. And the two counties came together and created a joint powers agency to actually do this. So currently, we are 1.2 million members strong. So 1/4 of the population of the Inland Empire is part of our IEHP membership. That is an incredible opportunity to actually move the dial on health that other counties across California do not have. We have about 6,300 providers. And although that seems like a really big number, we have the dubious distinction of having one of the highest patient-to-provider ratios in the state of California. We've been hard hit by the physician shortage. And we have about 2,100 team members that are caring for those 1.2 members. IEHP changed a lot after the Accountable Care Act. Prior to the Accountable Care Act, we were a kid plan with a few adults that were thrown in. So 2/3 of our membership were kids, 1/3 of our membership was adults. After the ACA, we've changed so that adults make up slightly more than half of our population and kids make up slightly less than half, although they are still a large portion of it. And as you can see, we have a very ethnically diverse community that we take care of. But at the same time, language, when our members are asked, English is overwhelmingly their first choice, which tells us that they are second-generation citizens, at least. And if you look at what we care for and our most common diagnoses, you see that number one in both Medi-Cal and Cal-Medi-Connect is our Medicare product, that number one, sadly, is pain management. And that is a very telling statistic across the United States that the opioid epidemic has not spared us either. Then you look at asthma, which is overwhelmingly being experienced by our children. You look at diabetes and then heart disease, morbid obesity. These are all lifestyle and environmental stress diagnoses that IEHP takes care of. So not to make you experts in how we measure quality from a health plan or a provider standpoint, but HEDIS measures were put forth by the National Committee for Quality Assurance. There are 90 measures in 6 domains, and we use those measures to measure how well our provider's doing, how well we as a health plan are doing, to be able to track how we are providing care over time and how our interventions are working. So if you see some of the interventions that we have put some extra time and energy into are a lot around children, asthma medication ratios, well child visits, childhood immunizations, and diabetes care. And we're going to talk a little bit about those today. So this slide. This slide is for all of you GIS professionals in the world who are looking at how do we do this and what are we using. For me, this is my mea culpa slide. And the mea culpa is that with a gun to my head, I could not make a map. So that being said, I am supported by an amazing team. And that team, I have 2 of them here, Will McConnell and James Martinez, otherwise known as Beanie, that help create these maps and allow me to play with them. The reason that I love maps is that they are the ultimate equalizer. Maps create a picture, and pictures, like art, tell stories. So I can take a map, or I can take data. Data, you look at me, and it's like, this is not my thing, I don't know anything about healthcare, and your eyes roll in the back of your head, and it's all over. But a map does something different. A map can go to a public official, a map can go to a provider, and a map can go to a community, and all of them can see the truth in the map. And that is why I love maps. So now we get to have fun with maps. So this is school absenteeism and asthma. The background is zip codes, and the colors of purple represent the air quality in our basin. It doesn't take a rocket scientist to figure out it kind of stinks, right? But when you look, the little cross there is one of our largest federally qualified health care systems that we have, called SAC, and around it in a radius, a 2-mile radius, are all the elementary schools that are in that area. And when you look at absenteeism and asthma in the schools, there's almost no school that is neither yellow, orange, or red. So the air quality and the management of asthma is affecting our children's ability to learn. That's the end outcome. So Karen, what can a health plan do about that? You're not a school, right? Well, we can do something about that. Here's our map. So this is a hexbin map, and for those of you who are familiar with GIS, you will know that a hexbin is taking our patient-specific data in a 5-mile radius and then turning it into a number that then communicates. This is really important to us in healthcare because of our privacy rules that we have through HIPAA in the United States. So most maps we would create several years ago, we could not share outside of our own group because they could then lead to people knowing who we were talking about. And so the hexbin map is something that's really been pivotal and transforming what we're doing. And as you look on this map, you see that there's incredible areas of opportunity. On the base of this map is our school districts and where their boundaries are. So we can look, because they're a natural partner for us, to be able to use them for education and perhaps even implanting some healthcare system inside the schools to be able to help these children control their asthma and learn. The little green dots that you see are our providers, our pediatric and our family practice providers who are taking care of our members. And we can tell that there are areas that are in the purple that we don't have a lot of providers. So what do we do about that? Do we partner with different providers to increase their sites? Do we contract with providers in certain areas that are high quality? How do we address those concerns? And then you will look at the little blue. Those are our community information centers, which are our outreach to the community to provide education, to start making a difference. And where are they in these areas of opportunity? Another map is our well child visits, where children need to be seen a number of 6 times throughout the course of the first 15 months of life. And you look, we're doing a little bit better on this one. And we've been putting a lot of time and energy into supporting our providers so that we can get children in, because that affects their childhood immunization status. And you see we have lots of opportunity, especially around San Bernardino and then that eastern Riverside area, that we have children who are not getting the vaccinations that they need early in life to prevent commonly communicable diseases. So here is one for adults. And I like this map because it shows us how well are we controlling diabetes through hemoglobin A1Cs in our community. A hemoglobin A1C is the ability of a lab test to tell us what someone's blood sugar is over the course of a 3-month period of time. And so the higher the number, the poorer the control. When you look, we have a lot of opportunity, but you're beginning to see some areas of white where we've had some real success. And those hot spots on the good side are just as important as those dark spots. Another thing when you look at, the green providers are our primary care providers and dispersed, and the red ones are our endocrinologists. I don't know if you can notice that there's a notable absence of endocrinology in the Temecula, Corona, Riverside, Hemet area. That is an area of opportunity for us, because we know that the farther you have to go to be able to get health care, the more likely you're not going to go, especially in a population where transportation is a barrier. So now we're going to talk a little bit about our shared savings program. Shared savings is our first foray into what we call value-based care. Value-based care is going from paying physicians, hospitals, and other providers on a widget basis. You do a thing, I pay you a check. It's going to a coordinated care model where a team of people work together to care for members and to get the best quality care, avoiding things like emergency rooms for primary care services. And so through this shared savings model, our partners that have signed up for this are able to share in the savings that they are able to create by providing a much more high-quality coordinated care network. So you can look, the background of this Hexbin map is members in the last 3-month period of time that were seen in the emergency room 3 times or more, which is a sign that to us that we have a lack of coordinated care for those members. And when you look at who our partners are, they're strategically placed in the areas where we have particular need to be able to get members into good primary care. So we're going to talk a little bit about a couple of those partners. So SAC, which is a FQ we talked about earlier that is in downtown San Bernardino. So most of you have seen the little data map on the back on the far left corner, right? How many of those of you, anybody seen those when you've gotten information from someone? Okay, great. So what does that tell you? It certainly tells you you've got lots of opportunity, that your members, the dotted lines are the IEHP baseline. It tells you that, well, you're above that, and that your members are accessing the emergency room in far higher proportions than other IEHP members across the system. But does it tell you anything else? It really doesn't. Now we go to our heat map. If your SAC, which is the red cross right there in the middle, and you look at this map, now just by adding a geographic location for those members that are high utilizers of the ED, you can see one, where if you were going to expand your clinic's access, you can see where it might be a good idea to go. You can also see that, you have a lot of opportunity just around the mothership, and that people close to SAC are not getting into the system the way they need to avoid the emergency room. So maybe you would increase your hours. Perhaps you would look at the number of providers that you had. Perhaps you would look at coordinating their care with different mid-levels or outreach programs. But you can do that and realize that you're going to be able to affect a lot of members and improve your shared savings participation by really looking at what's around your mothership. This is another map for those same members about where they're coming from. And you can see that their catchment area for their assigned membership is pretty great. It's coming from far outside that 20 to 30 mile radius, which we consider optimal for a clinic site. And so what are the options there? What should IEHP do about that? Should we look differently about assigning members? Should we get them closer to home? What are the kind of decisions that we should make to be able to provide more optimal care when we are dealing with membership? The next map I just love. This is another shared savings partner. This is Riverside Health System, University Health System, and they are the Riverside County Hospital System with their clinics. So the little blue dots are all their clinics. The red heart in the middle is their mothership, their hospital, and their main clinic site. And you look at where these members who are high utilizers of the ED are going. And they're driving like right past a clinic to go 20 miles out of their way to another clinic. This is very helpful to RUHS. They can look at this and they can say, oh my goodness, maybe we need to look at our assignment. Are they driving that far because what those members need is not available in the clinic that is close to home? Or is it that we just haven't done anything to make sure that they're at a clinic close to their house so they can get there more easily? Because the farther they have to go, the more likely they're not going to go until something is really wrong. So social determinants of health is our next big challenge for delivering health care. Social determinants of health are the environmental stress factors that affect health and actually mortality. Things like the level of education, housing insecurity, food insecurity, unemployment. These are all things that affect human beings and their ability to thrive. So we use Esri's Living Atlas and community analysts to be able to give us a lot of these social determinants of health looking at our communities. Our ultimate goal is, Will McConnell is working with our providers to be able to get social determinant of health data directly from the provider into IEHP. Currently, providers do an assessment for social determinants of health, but sadly, that information stays with them. And they may give a referral for housing, they may give them the addresses of a food bank, but we never know if they've actually followed up, and it's completely blind to the health plan. Through Z codes, if our providers bill them to us when they bill in their interaction with our member, we can get that data. And then we can also intervene and begin to close the loop on these social determinants of health, as well as be able to assess what the real problems are and where they are, and use GIS for that. So more to come on that. But if you look at homelessness, you can tell that homelessness in the Inland Empire is a big problem. We have tried to combat that by starting a small pilot of a homeless initiative where we're trying to take medically fragile members and to place them into housing. So one of our first projects, we've now placed about 109 members into supportive permanent housing. And this is one project that we are supporting, which is a housing project in Bloomington. Bloomington is a very challenged area in the Inland Empire. And this housing project will give us 10 units over the next 20 years. But one of the things that we did was map out what are the assets that are around Bloomington. So when you look at this, in a walking distance of 2 miles, you see one full-service grocery store. You see half a dozen pharmacies. You see, sadly, 7 or 8 liquor stores, all within a few blocks. And you see at least a dozen fast food restaurants. And I ask you, is it any wonder that the lower income members of our community are struggling with their health when that is what you see around them? This is that same housing project looking at fruit and vegetable spending in and around that area. And sadly, that is less than $260 a year on fresh fruit and vegetable spending. I don't even know how that's possible. So we have a lot of opportunity to try to mitigate some of the circumstances, even around the housing project that we are supporting. This is one of our projects that we support, which is called Mobile Fresh. And it was actually started by a group of students at La Sierra University in their Enactus program. They raised money and they got a decommissioned bus from RTA, Riverside Transit Authority, and they took the money that they had and they made it into a mobile grocery store. They actually used GIS mapping to figure out where the food deserts were in Riverside City and created a path for the van to go and to deliver fresh fruit and vegetables. And they've expanded, it's now part of Riverside Family Associates. And they've taken over control of it and we help support it. But this is something that we may need to increase its ability to be able to help other communities outside of Riverside. So in closing, making an impact. I hope that the one thing that you take away from this presentation today is that creation of health in our communities is not about health care. Health care is really only a small part. It's about planning. It's about government choices. It's about businesses and them being good partners in their communities. It's about having clean air and good transit. All of us play a role in getting health into our communities. Abigail Adams once told her husband, John, that a rising tide rises all ships. And for all of you in all the sectors that you represent, go forth from here and at least think this one thing. Ask yourself this question. In my community, what am I doing to raise the tide? Thank you.